Good morning, everyone. My name is Lauren Richards. I work for King County Crisis and Commitment Services as one of the designated crisis responder supervisors. A few things to note before we get into the presentation. We do have an ASL interpreter today. We are also recording this video so that we can make it available to folks in the future. So please do be aware that everything that's going on today is being recorded. There will be time at the end if you have general questions or would like to discuss anything. So please hold those kinds of questions till the end. If you have a question or comment about something that I'm currently speaking on and you would like to interject, go ahead and drop that in the comments. One of my coworkers, Samuel, is also on the call and he's going to be managing the chat and will let us know if there are any questions. So with that, we will go ahead and get started. So what is Crisis and Commitment Services? We work for King County. We are a county-run agency. There are about 45 career service designated crisis responders. We have several per diem designated crisis responders. We have administrative staff. We have 5 supervisors, a coordinator, and then we have everyone up at ITA Court, which are the folks who decide what happens after the DCRs do the initial detention. And up there, we have prosecuting attorneys, defense attorneys, judges, paralegals, administrative staff, a whole bunch of folks up there. We also work with law enforcement, criminal courts, mental health court, family members, community providers, neighbors, pretty much everyone in the county we work with. And so what is a designated crisis responder, or what we refer to as a DCR? So we used to be called designated mental health professionals, and when the law changed in April of 2018, they changed our name to DCRs. Before we were DMHPs, we were county designated MHPs. The legislature likes to change our acronyms every now and then. So DCRs are employees of King County Behavioral Health. Most of us are master's level clinicians. There are a very small handful of exceptions, such as some nurses. We all have at least 5+ years of experience with crisis assessment and working with folks who have behavioral health issues before we become designated crisis responders. When you get hired as a designated crisis responder, you get intensive training in the law and the investigative process. It takes about 3 to 6 months from the time someone is hired until they are practicing independently. DCRs are the only individuals who can make the decision about whether or not someone meets the criteria to be detained under the law. We do the entire process. We take the intake, we investigate, we evaluate, and then we fill out the legal paperwork with the court before turning the process over to the hospitals and the courts. There is sometimes confusion between what a DCR is versus a mental health professional. Washington state law does define what a mental health professional is, but just because someone is defined as a mental health professional doesn't mean that they can detain someone for involuntary behavioral health treatment. It is only designated crisis responders that can do this, which is a different model than some states. Some states, the doctor decides. Some states, people have to petition the court directly themselves. This model where there's an independent practitioner making the decision is fairly unique, and there's only a handful of states that do this. And so how did we end up with this process? It started with deinstitutionalization. This was the process of downsizing large psychiatric hospitals and establishing mental health care in individuals' local communities. It was actually JFK in 1963 who signed the Community Mental Health Act, which transferred the responsibility from federal law to state law because they wanted patients to get care in their communities. Before these types of laws went into effect, it was pretty easy to take someone to the hospital against their will for treatment. A husband could take his wife who he thought was having issues, a parent who had a child who was homosexual, or, there are a wide variety of issues that could lead to someone being taken to a hospital with no judicial oversight, and the person could be held there as long as the providers and the people involved thought was possible. So in Washington State, our laws went into effect, the RCW 7105, which are the laws that dictate what happens during an adult detention, were enacted in January of 1974. And then there was a law pertaining to minors, 7134, which came into effect in 1986. There have been significant amendments over the years. We'll talk about some of these later, but the legislation is constantly tweaking things based on what's going on in the community and what they're hearing from their constituents. So sometimes we're having to adjust our practice based on what's going on in the legislature. And an important thing to keep in mind with this is everything that the DCRs are doing is dictated by law. We are not just making arbitrary decisions about who should get treatment, who shouldn't, whether or not someone deserves treatment, anything like that. We are following the law and deciding whether or not someone meets criteria under the law. So the intention behind the law when the legislature put this in effect was to put an end to the inappropriate, indefinite commitments of individuals suffering from behavioral health disorders, to protect people's individual rights, to provide continuity of care, to make sure that all existing services were being used and we weren't wasting money on duplicating services someone was already receiving, to encourage individuals to get care in their community whenever possible and not taking them far from home from their natural supports, and to protect public safety. Now, what's really interesting to me is what is not on this list. It doesn't say anything about a person needs treatment, that they would benefit from treatment. If you read this, this is ultimately a public safety law. And when we get into the criteria of what's needed in order to involuntarily hospitalize someone, that will become clear. But a big part of our laws, aren't necessarily to get folks treatment when they need it. It's about keeping them and individuals in the community safe. It is a public safety law. And just one more note on that, some states do have more liberal laws in terms of making it easier to detain someone simply because they need treatment. So here in Washington State, they're pretty conservative and more about protecting someone's rights of not taking away their rights and forcing them into the hospital if they don't need to. So RCW 7134 was the law that came into effect for adolescents 13 to 17 years of age. Once you're 18, the adult statute applies. If you are under 13, it is only your family or guardian or whoever's responsible for your care that can initiate involuntary treatment. We do not accept referrals on individuals younger than 13 because the law does not allow us to do anything. The criteria for adolescents is the same as the criteria for adults, which the adult criteria we'll go into in depth later, except without needing imminence. Instead of there needing to be an imminent risk of harm, it's a lower level. There only has to be a serious risk of harm. And the idea behind that is, adolescence is already a turbulent time. There's a lot going on emotionally and mentally. We also want to make sure these individuals are safe. So there's a little bit lower level of evidence that's needed in order to hospitalize a minor against their will rather than adults. There's also a process called family-initiated treatment that any parent, guardian who's ever providing care for this minor can initiate this process called family-initiated treatment. The provider at the hospital still has to agree that there is a need for treatment. It can't just be that the parent says, I want my child hospitalized. There has to be a valid reason for the individual to be detained. I'm seeing some messages. Let me chat real quick. Can everyone see the PowerPoint and the interpreter? You can unmute and let me know. Or give a thumbs up if Sam has it.
Yes, we can. or I can.
Okay, it looks like folks can see both. Fantastic. Okay.
I think they need to look, I had the interpreter showing up in my view.
Okay, so where
and if you look
evaluations
down
happen.
into the
Okay,
corner,
so
that's
designated crisis responders will meet a patient anywhere they are. We go to jails, emergency rooms, psychiatric hospitals, medical units, people's homes, apartments. We go to courthouses, nursing homes, homeless shelters, group homes. We will even go see an individual who is homeless, but we need to have some sort of location. Unfortunately, we don't have the resources and bandwidth to be able to go out in the community just searching for individuals. King County is quite large. But we'll go to homeless encampments. If you can give us an intersection, a area, a tent color, a physical description, we will do our best to go and find that individual. So we go anywhere where the person is that needs services. Okay, and so what are the conditions for detention? This is what the law dictates, what is necessary in order for us to take away someone's rights and put them in the hospital for treatment against their will. So first, we have to have evidence that there is a behavioral health disorder and that the symptoms of that behavioral health disorder is presenting a likelihood of serious harm either to the patient, to others, to the property or others, or is causing the individual to be gravely disabled under the law. There must be a nexus present between the symptoms and the risk of harm. The risk of harm has to result directly from the symptoms. Having severe mental health symptoms alone does not justify detention. People with behavioral health symptoms can live healthy and meaningful lives. Not everyone experiencing symptoms requires treatment. So some examples of where there might be symptoms but no risk, and an example would be a homeless man who has symptoms of depression and cannot afford food and is losing weight because he cannot get food. The problem there is an issue with resources and not due to his symptoms of depression. So in that sense, you know, there would be nothing a psychiatric hospital could do to address that. That doesn't meet criteria under the law. Another example would be someone who suffers from bipolar disorder, is diagnosed with cancer, and is refusing treatment because they don't want to endure the painful side effects of chemotherapy. That's a person who's making an informed decision. Individuals with behavioral health disorders or symptoms have the right to refuse medical treatment, just like anyone else. It would be a different story if someone was hearing voices telling them that if they just drink, 6 gallons of water a day, that will cure their cancer. And so that's why they don't want treatment. That would be different because that would be the symptoms directly creating the risk of refusing the treatment. But something important to remember is that just because someone is hospitalized psychiatrically against their will, they still cannot force medical treatment. The idea is you treat the symptoms of the disorder and hope that the person makes a better decision in the future, but they can't just force medical treatment. So behavioral health disorders, these are the legal definitions. The law defines a mental disorder as any organic, mental, or emotional impairment which has substantial adverse effects on an individual's thoughts or actions. So what sticks out here is that this is a very broad definition. It doesn't mention anything about diagnosis through the DSM or a psychiatrist. It can cover things like dementia, a traumatic brain injury, even grief. So the law intentionally left this very vague and broad so that it could be applied in a variety of situations. Substance use disorder is a little bit more straightforward in how we think of substance disorder in a clinical sense. It's a cluster of symptoms where an individual continues using despite significant substance-related problems. And yes, the slides will be available after the training. I will send out the slides as well as a blank declaration form, which we'll talk about later. So what does the law define imminence as? It means something that is going to happen very soon rather than something that could happen in the future. So we often get asked, what exactly is the timeline for imminence? And the law doesn't define it. And there are different factors that can influence, what makes something imminent or not. So, sometimes we will get a referral about someone who is reporting that they are feeling suicidal and have a plan to try and harm themselves on their birthday, but their birthday is 8 months from now. If someone made that referral, we would suggest to them to keep monitoring the situation. And as it got closer, we could potentially get involved. But 8 months out, that's pretty far off in the future. And there's not a lot that the law lets us do about that. So generally speaking, it means if something bad's going to happen in the next week or so. So there are 4 major sets of criteria for being committed. The first is harm to self. It's when there is a significant risk that the person is going to harm themselves. They're making threats to harm themselves. They've attempted to harm themselves. Or it could be that they have a history of harming themselves and are beginning to act in a manner that is consistent with that. Harm to others is behavior which causes another individual to have reasonable fear that they are at physical risk of harm. It could be that this person is yelling and screaming and angrily posturing in the person's face in a way that makes them feel that they could be assaulted. They could be making threats to someone. They could be already engaging in assaultive acts, or they could be making threats to harm someone. In terms of court, there are some specific caveats to harm to others with witnesses. Court really wants the person who was harmed themselves, because it's the person who is being threatened or assaulted that they want to hear from about how they felt in that moment. Now, if there's a situation where someone was seriously assaulted and a witness can say they were, hit in the face and blood was coming down their forehead, that also can work. But especially for a threat, it's the person who was threatened who needs to be able to say the level of fear that they felt. I won't get to the specifics, but there are times, where someone might make a threat, but where the individual being threatened doesn't take that seriously or doesn't believe that it's a valid threat. So it has to be that the person being threatened physically fears that they could be harmed. And then there's property damage. This is behavior which results in a substantial loss or damage to the property of the person who owns it. So a patient can damage as much of their own property as they want, and the law doesn't let us do anything about that. It has to be property that belongs to someone else. If someone's renting an apartment and they're doing damage in the apartment, that qualifies. If they're doing it in a home that they own, that would not qualify. There used to be a monetary value assigned to the property where it had to be $100 or more. That is no longer in the law, and it is up to the person who owns the property to decide whether or not it is a significant loss to them. The reason for this is sometimes things that are being damaged don't necessarily have any street value. Sometimes individuals, when they are decompensated, might do things like tear up family photos or things that might have a lot of personal significance to someone but has no monetary value, and the court considers that as well. Then there's grave disability. This is the least straightforward criteria. There are 2 prongs to this. The first is that the person is putting themselves at risk of physical harm because they are unable to provide for their needs of health and safety. So that's basically someone's symptoms are impairing their ability to provide safe care for themselves. So it could be that someone is so depressed that they've lost their appetite, they're not eating, they're losing weight, and they are starting to experience medical side effects because of that weight loss. It could also be that someone is hearing voices, they are so distracted by their voices that they can't physically keep themselves safe. They are crossing the road in traffic, doing things that could put them at risk of harm. Prong B, the individual has shown a deterioration in routine functioning, evidenced by a repeated and escalating loss of control over their thoughts and actions, and they're not receiving services to keep themselves safe. Prong B is basically a person is so impaired, they don't know where they are, they don't know what's going on. We maybe don't have a concrete example of how they are going to come to harm, but it is very obvious this person is so psychotic that they are unable to function and keep themselves safe. So if there is a medical issue that's going on that's creating the risk, so another common example of grave disability would be someone, we talked a bit about this earlier, the cancer example, where someone could be experiencing a medical illness and they were refusing treatment because voices are telling them something, or they have a delusional belief. If the person is already experiencing a medical crisis that could put their life at risk, it has to be a medical professional that testifies to that. I, as a master level mental health practitioner, don't get to say that someone has sepsis that's putting their life at risk. I'm not a medical professional. I don't know how to interpret labs. So the court needs to hear from a medical provider. Now, there are some situations, right, where someone's refusing to see a medical provider. There's no way you can get a nurse out to see them. Let's say they've got a wound on their leg. It's becoming obviously infected. You might not be a medical professional, but it's getting swollen. Pus is coming out of it. It's not smelling great, things of that nature that you can physically observe. In those situations, absolutely, non-medical professionals can testify to that. There are some concerns specific to substance use. Previously, before I believe it was 2018, the law changed where we used to only be able to detain for mental health disorders. We can now also detain for substance use disorders if that's what's creating the risk of harm. So some specific concerns for substances, we're going to want to know, what do they use? How long have they been using? How do they normally use the substance? What kind of behaviors are they engaging in while they are intoxicating that is creating the harm? If they're being seen in a hospital, we're going to want to know how the UTOX panned out. We're going to want to know, are there concerns about withdrawal? Have they been in treatment before? And are there any medical issues resulting from their care? But the law has us look at substance use and behavioral health disorder, substance use disorder and mental health disorder the same. If the symptoms of those disorders are creating an imminent risk of harm, that's what we need to be able to put the person in the hospital. And you don't even necessarily need to tell us whether or not it's substance use or mental health symptoms that are driving it. I think all of us as clinicians understand that there are often overlapping disorders. Non-emergency detentions. So the legislature also gives designated crisis responders an option to detain individuals who might not be presenting as an imminent risk of harm, but with a serious likelihood of harm, but no imminence. So the way this process works, because there's no imminence, this would be a situation where maybe there's something a little bit off in the future that could be happening, where a common example of this is someone is depressed, they're laying in bed, they're not eating, they may not be suffering medical consequences yet, but they are literally spending all of their time laying in bed, they're not getting up, they're losing weight. Currently, there's no significant medical concerns. However, it's pretty obvious if this behavior continues, that's where it's going. So in that situation, DCRs do not have the authority under the law to detain someone immediately. What they do is they need to go to a judge to get an order to put the individual in the hospital. So in an emergency detention, the designated crisis responders see the person, decide they meet criteria, fill out the paperwork, and send them to the hospital right away. For a non-emergency detention, it's a different process. They evaluate the individual, they come back to the office, they fill out the legal paperwork, and they submit it to court to get a judge to approve the order. So it is the DCR that is basically making a clinical recommendation to the judge that they believe this person needs to be detained, but it is the judge that is signing off on the detention. It is rare that judges don't approve our petitions, but the non-emergency petitions, but it does happen sometime. It's typically because there's a risk, but we haven't demonstrated that there is a behavioral health disorder creating that risk. So in this situation, once the judge approves the petition, they send it to us, and then the DCRs go back out, serve the order, and hospitalize the individual. Once the individual is in the hospital, it's the exact same process as if they were detained on an emergency. There's no differentiation in the process once they get to the hospital. Everyone gets the same treatment. It's just the process that gets them there. Okay. Statutory timelines. So the legislature dictates how long we have to respond to certain types of referrals. For jails, homes, apartments, mental health agencies, anything out in the community, the law does not have any kind of timeline. We're allowed to take as long as we need to get out and see the person. We receive court orders from criminal courts that are dismissing criminal charges and referring to us instead. We get 3 days, 72 hours, not including weekends and holidays, to investigate and go out and see that person. There are a lot of different considerations for emergency rooms and hospital referrals. I'm not going to get too much into the weeds. Depending on the situation, we have 6 to 12 hours from the time the referral is made to our office to get out and see the person. The reason for this is because the person is being held against their will in the emergency room or on a hospital unit, waiting to be seen by us. So, you know, a person's rights can only be held for so long while waiting for us to come and see them and forcing them to remain in the hospital when they don't want to be there. So that's why we have to respond in that amount of time. So the main takeaway from this is why DCR triaging of cases can get so complicated. Individuals out in the community, we have no timeline. Whereas if a referral comes in and, you know, we might get a bunch of hospital cases at once, we might have to reroute individuals out in the community to send them to hospitals instead because we legally have to meet those timelines. If we don't meet those timelines, those cases will not hold up in court. The person will get released before they ever even listen to the merits of the case, anything clinical. They will dismiss the case because the individual's rights were disregarded. So this is also why individuals in the community tend to have to wait quite a while for us to get out and see them, because we don't have that timeline. DCRs have different feelings about this. It can sometimes be difficult because we know someone who's in a hospital waiting for us to come and see them is being kept safe. Whereas someone at home, you know, their parents and family or whoever's around may be the only ones providing the safety net. So it's really difficult for us to leave folks waiting in the community, but the law really gives us no choice. So after the DCRs have come out, made their decision, and put the person in the hospital, what happens next is up to the Involuntary Treatment Act courts, as well as the hospital where the person is detained to. So once the DCRs have come in and made our decision, we are no longer involved in the case. The hospital provides treatment and the court decides what happens from there. So a few different things can happen. So when the DCRs detain, we detain for up to 120 hours. That's 5 days, not including weekends or holidays. So it tends to end up being about a calendar week. If during that week, the hospital is able to come up with a safe plan to discharge the person, they can do so at any time. If they think the person needs to stay longer and the person is willing to stay voluntarily, then they will make a plan to do that. If the individual is like, no, I would like to leave, but the hospital does not believe that it's safe to do so, the hospitals employ evaluators who go and see these individuals prior to their hearing to decide whether or not they feel they need to be held longer. And if they do feel they need to be held longer, the hospital files paperwork with the court to have the individual held longer. And then there is a court hearing. So what are they looking at court? They are looking to see were the legal steps and safeguards followed. So did the DCR serve the correct paperwork? Did we meet the timelines? Did we follow the law in detaining this individual? Was there an attempt to avoid detention? Because another part of the law says, yes, there has to be symptoms of a behavioral health disorder that are creating a risk, but there also can't be any less restrictive treatment options that the patient is interested in. So someone could be presenting as a risk of harm because of their symptoms, but if they're willing to be voluntarily hospitalized, if we can create a safety plan with family and friends until they get an outpatient appointment, anything like that, we call that a less restrictive, and the person would not be hospitalized. So the court's going to be looking at, did we look at other options that could have kept the situation safe? They're going to then be looking at the symptoms of the behavioral health disorder and how that is creating a risk. They're going to try and see at that step whether or not there is a way to provide that treatment at a lower level without having to force the person to be in the hospital. And is there a way for the person to get treatment without the intervention of court? At every step of the process, everyone is constantly looking for what is the lowest level of treatment, the least restrictive amount of treatment we can provide for this person that keeps them safe and the community safe. The other thing you'll notice on this is that before they ever get to any of the information about the symptoms or the risk, they're first looking at the legal steps and making sure those were followed. Every individual who is detained is assigned a defense attorney. The defense attorney is like any other attorney out there. They are duty bound to argue for what their client wants. So the patient can be saying, you know, the second I get out of this hospital, I'm going to kill myself and I want you to get me out of this hospital. The defense attorney will argue to get the individual out. So it's very much a legal process with attorneys involved and a judge listening to all the evidence and making decisions. So like I said, the DCR detains for up to the initial 120-hour period. If the hospital wants to hold them longer, they petition for a 14-day order. At the end of that 14-day order, if they still think they need to be held, they will petition for a 90-day order. If that 90-day order comes up and they still don't think it's safe to discharge the individual, they then petition for 180 days. At that point, if the person remains in the hospital, it's every 180 days there's a court hearing. Most cases get resolved on the 14-day hearing. So it's not common, but it does happen where folks get held on the 180-day orders. And like I said, at every step of the process, the court and clinicians are looking at, are we able to achieve this treatment and keep folks safe at a lower level without having to keep the person in the hospital against their will. So for case managers, mental health and substance use disorder case managers, we do have some expectations on these individuals. We expect that you know your clients, you're actively involved in their treatment, you can recognize the early signs of decompensation and are aware of the interventions that can help avoid further decompensation so that you're actively involved in the less restrictive process. And that you have effective crisis plans that are available after hours through crisis connections. So that if we see your client on a weekend or after hours, we can have some ideas about, you know, their typical pattern of decompensations and the kind of interventions that typically help. One of the outcomes at a court hearing is that someone can be put on a less restrictive order. So this would be the court ordering a less restrictive type of treatment and releasing the individual from the hospital. So these orders are typically 90 or 180-day orders that have specific terms for outpatient treatment that the individual needs to follow. It's typically that the person must reside at a certain location, follow treatment recommendations from their providers, refrain from acts of harm to self and others, things of that nature. So just because someone is on a less restrictive order does not mean that they cannot participate in voluntary treatment, including voluntary hospitalization. If the person wants to be hospitalized and it's appropriate, that can happen voluntarily. But being on this order allows us to have a lower level of evidence needed to put them back in the hospital. So the criteria for that, if you have a loved one or a client who is discharged from the hospital on one of these orders and you believe they need to be back in the hospital, The legal criteria in order for us to put them back in the hospital is that they need to be not following one of the conditions. So they're either not taking meds or they're threatening others, they're using drugs, something on the order that's a condition. They are not complying with that. And there needs to be either a significant deterioration in functioning or a likelihood of serious harm. So we'll sometimes get calls saying, you know, my client is on a less restrictive order. They refuse to take their medication today. I'd like to have the order revoked. It's not enough. This isn't like behavioral health probation. It's not meant to be punitive. I think we all know that there is not just a infinite amount of psychiatric beds available. So, you know, there needs to be a need for treatment. And so that's why we need to be able to show that the person is significantly decompensated from their baseline. So it's not necessarily that the person has to be presenting with the risk of harm. Being significantly decompensated is enough. So, you know, this is a person who's on a less restrictive order. They've stopped taking their medications. They're now hearing voices, talking to themselves. Their kind of general pattern of decompensation. So we do need folks. So I'm going to go through and talk about some of the changes to the laws over the years. In 2014, there was what we call the expansion law that went into effect. This is a law that's really great for us to use. It basically allows us to detain someone who has a history of being detained, is currently presenting with the early signs of the kinds of decompensation in the past that have led to change. So it's basically using the knowledge that past behavior is the best predictor of future behavior. And so what the law says is that symptoms or behaviors on their own that wouldn't necessarily usually result in a finding of meeting criteria to be detained will warrant detention if these symptoms or behaviors are closely associated with symptoms or behaviors that previously led to past involuntary hospitalizations, severe deteriorations, or one or more violent acts. These symptoms are a departure from baseline for the individual, and without treatment, they will continue to get worse. So this would be an individual who in the past stops taking medications, maybe then stops eating, starts talking to themselves, then starts making threats, and then has seriously assaulted people. That's a pattern that they've shown in the past, and perhaps they've been detained during that or severely assaulted someone or something of that nature. So now the person is stopped their meds, they're not eating, they're starting to hear voices. You know, on their own, normally that wouldn't present a risk of harm. We wouldn't be able to detain. But we know in the past that after this comes the person making threats and then assaulting people. So in that situation, we could use the history, the pattern of decompensation from the past to put the person in the hospital before it gets that bad. So this is a way of trying to intervene early enough so that the person doesn't actually have to threaten or harm or, you know, harm themselves, others, or become gravely disabled before we're able to intervene. So that's a great law that we like using because then we don't have to wait for threats or bad things to happen. In 2015, there was the Jones Law Amendment. And what this basically says is that a direct family member, which the law defines what a family member is, I can't think of all of them right now, but it's basically mom, dad, sibling, grandparents, things of that nature, can petition the court directly to detain an individual if we have seen the person and decided they don't meet criteria, or if the person was referred more than 48 hours ago and we haven't taken steps to detain the individual. So basically what this means is if we evaluate someone and say, no, we don't meet criteria, we're not detaining, the family has 10 days to go to the court and fill out a petition to say, I think the DCRs made the wrong decision. This is why. The court then asks us for our side of the story. We provide some documentation and explain why we did not detain. And then the judge decides whether or not they're going to issue an order to detain. If they do issue an order to detain, they send it to our office and the DCRs go pick up the individual, send them to the hospital, and then it's the same process that we've been talking about throughout. The other time that a family member can do this is if they call, make a referral to our office, 48 hours passes, we haven't been out to see the person or taken steps to detain them, that family has the right to also petition court and say, hey, DCRs haven't been out. This is why I think the person needs to be detained. With our current volume of cases, we almost never get out within 48 hours in the community. So the higher our volume is, the more of these that we see. And over the years, the court has, issued several orders for us to go out and detain individuals. Sometimes overriding our decision, but more often because it's been over 48 hours since the referral was made. So it's the judge making the decision and deciding whether or not the evidence meets criteria under the law. So in 2018 is when Ricky's Law came into effect. And that's when the law changed from only being able to hospitalize someone for mental disorder to being able to do mental disorder or substance use disorder, both of which fall under behavioral health disorder. It's the exact same criteria for both. It has to be that the behavioral disorder, so the substance use or the mental disorder symptoms, are creating the risk of harm. There are a few differences between mental health and SUD detentions, though. The intent of the legislature is to integrate mental health and substance use treatment, but we're not completely there yet. For substance use disorders, an individual has to go to what's called a secure management withdrawal facility. We have one of those in King County. There are 16 beds, and we're not able to transport to any of the facilities outside of our county right now. So if someone is detained for mental health disorder and we're unable to find a psychiatric bed, we can fill out what's called a single bed certification. The state approves it, and the person remains at the emergency room or the medical hospital where they are until a psychiatric bed becomes available, and that allows the person to be held under the law. However, if we are detaining only for substance use disorders and they have to go to one of these secure management withdrawal facilities and there's no bed available, we are not allowed to fill out one of these SUCs. So in that case, we have to fill out what's called a no bed report, saying this person met criteria under the law. I would have detained if there was a bed available. However, there is not a bed available, so we basically have to walk away. Fortunately, we don't have to do that a lot, but it is really hard when we're basically saying, yes, this person is at risk, but there's no bed, so we can't detain. Another difference is that for the court process, there's nothing after the 14-day hearing for substance use disorder. That's the longest that someone can. In 2019, there was an amendment to firearm rights related to individuals who are being detained. It has always been that any person detained on the 14-day order by court, so once court orders a commitment, they lose their gun rights permanently. For whatever reason, this does not apply to substance use hospitalizations. We all have a lot of thoughts and feelings on that, but I won't go into it. The person can petition the court to get their gun rights back. If they can show that they're no longer a risk and they can't have their gun rights restored if they petition the court directly. Starting in 2019, anyone detained by the DCRs for that 120-hour initial period automatically loses their gun rights for 6 months. This one does apply to SUD detentions, and as long as the person isn't subsequently put on a 14-day hearing at court, their gun rights would be restored automatically after 6 months. So the only time this doesn't apply is if the person is detained only for grave disability. The reason behind this is because the law says that there has to be a risk of harm to the person or others in order to restrict their gun rights. So there are situations where we detain individuals. It's actually more common that people get detained for more than one reason. Someone can be gravely disabled and a danger to others, in which case they would lose their gun rights for 6 months. Whereas if it's just grave disability, then they get to keep their gun rights. This comes up for us a lot with veterans, individuals who may want to work in law enforcement in the future. A lot of individuals we see don't have strong feelings about their gun rights, but some folks do. So, in 2021, there were some major amendments to 7105 and 7134. Mental disorder, the Initially, when substance use disorder came into the law, it specifically listed out mental disorder and substance use disorder. That's now combined under behavioral health disorder. It also increased the initial detention period from 72 hours, which is about 3 days, to 120 hours, which was about 5 days. The reason behind this was actually more administrative than for clinical reasons. Because our system is so backed up, folks are tending to be waiting for beds for a day or the first day or two of their inpatient stay. So hospitals were getting these folks with only 24 hours left in their detainment period. They didn't have time to get to know them, to decide whether or not they needed to petition the courts to hold them longer. So to err on the side of caution, a lot of hospitals were filing the 14-day petitions on a lot of individuals simply because they weren't sure yet. So this led to an increase court hearings. And so the idea behind this was hopefully it would give the hospitals more time to work with the individual and avoid the 14-day hearings. A lot of our budget goes up to court, so we're always trying to find ways to route that back to treatment. So that was the idea behind this. And the state is watching the statistics and data very closely to see if this has an impact on the amount of court hearings and the 14-day orders that individuals are getting placed on. A quick note about HIPAA and DCRs. What you see up here is actually straight from the law, but basically what this says is you do not need a release of information from your client in order to share information with DCRs when there's an open ITA referral. In the same vein, DCRs can share with providers the information necessary to provide continuity of care so that you can provide appropriate treatment. Basically, this is because this is a legal safety emergency process. So you don't need to get your client or patient's permission to share information with us. It's one of the few times where HIPAA does not apply. Now, if it's you're a family member or any non-professional, there is less information that we can share with them. But for direct family members, we can say that the person is detained and where they are detained and for how long. But we can't provide any specifics about what was said during our evaluation or anything like that. And the only individuals who can request their records from DCRs is the patient themselves. And we require a notarized ROI to provide those records. Consultation, DCRs will not consult with you about whether or not you should be making a referral. By the time you're calling us, you've decided you want to make a referral. If you are unsure if something warrants a DCR referral or if it's appropriate, consult with your supervisor before calling us. We don't give advice or discuss hypothetical cases. So if you call and say, hey, this is what's going on, what should I do? We're not going to provide advice. If you call generally to ask information about the law or a process, absolutely, we can talk about that. Just don't give us any specific names or scenarios. If you call us and with a specific client's name, we will consider a referral and we will be opening up a case. And we will be expecting you to let us know that you want us to evaluate the individual. So some safety concerns. Is anyone being actively harmed? Are there acute medical issues? Do police need to be involved? Designated crisis responders are not first responders. For referrals out in the community, unfortunately, right now, we have a real high volume. It can take us even several weeks sometimes to get out and see someone. So if you have a situation where someone is currently in that moment unsafe, they have a weapon, they're threatening to hurt themselves, they're harming other people, you're going to want to call police, resolve that immediate situation, and then get us involved once the immediate crisis has resolved and everyone's in a safe place. We're going to want to know about their past history of violence and suicide attempts, because that will inform the level of risk we think is involved. We're also going to want to know about elements of danger relating to the DCRs. We want to keep the DCRs safe too. Are there weapons in the house? In hoarding situations, are there biohazards? Is there mold? Are there children in the home that we're going to need to find placement for if we detain their parents? Are there children or pets being abused in the house? Are there pets that could harm the DCR? All that kind of stuff. And we're going to want to know, what have you attempted to do to keep the clients and others safe while you're waiting for us? For professionals, we ask for declarations. It's a legal document. I will send out a blank declaration form and instructions for how to send out this form along with the slides after this meeting. This declaration is going to be your first-hand account of mental disorder or substance use disorder, as well as the risk that's coming from that. It needs to be first-hand information. It can't be second-hand information. You can call us to say, I would like to make a referral. This is what's going on. I didn't witness it, but here are the names and contact info for the individuals who have, and we will then call them to gather that information. You can testify to clinical information if it is documented in the patient's official chart at your hospital or agency. Everything you put in your statement or report to us, the court may ask you to testify about that. If you put secondhand information in your statement, it will be considered hearsay. It's not admissible at court. Of course, if you need to put secondhand information in your declaration in order for it to make sense, to provide context, you can absolutely do that. But in order for it to be legally admissible, we will need the person who directly saw it to testify at court. The court is not interested in diagnosis, and neither DCRs. We're interested in behaviors and symptoms that are of concern. It can be a bit frustrating to us when we ask what symptoms the person is experiencing, and the answer is they're diagnosed with schizophrenia. Because we're really not concerned with diagnoses. It's really symptoms and behaviors that we're concerned with. So when you're making a DCR referral, you want to have your declaration written. For non-professionals, the DCR will take the statement for them. Non-professionals, like family members, neighbors, things like that, we would not ask them to write their own statement. The DCR will call them or speak to them in person, take the information and put it into a statement on their behalf. But if it's a professional making the referral, we want you to write your declaration before calling us. You're going to want to plan to spend 10 to 20 minutes on the phone with us. The phone numbers listed up here where you can call us. If you're professional calling about someone you work with, you call 263-9202. The general public calls 263-9200. But those are just routed slightly different to our answering service, which is through Crisis Connections. We do use as an answering service. The way it works is you call Crisis Connections, they take down all your information and they put it onto our phone log. And then we have DCRs who are in the office all day, every day, returning these calls. Our call volume can get incredibly high, especially the longer the day goes on. So it can take us a varying amount of time to return your call. The earlier in the day you call us, the sooner we can get back to you. But unfortunately, it is not unheard of for us to take several hours to get back to someone. So be patient. If possible, give us a cell phone number that you've got on you, because if we don't reach you, we'll leave a message and you'll have to call back and get put back on our call log and go through that queue again. But be persistent, be patient. We will get back to you, I promise. We don't leave folks hanging. Even if it's the next day, you will hear from us. So you're going to want to have the chart in front of you and be prepared to provide demographic information, clinical history. What medications are they taking? Have they been hospitalized before? Is there information about the next of kin? What are their symptoms? What is the risk? What less restrictives have been tried? And where is the person? So that we can try and go and find them. And like I said, we do need to know where the person is to be able to see them. We can't just go running around the county looking for them. However, you can make a referral saying, I don't know where this person is, but I think it's likely they will pop up in the next few days. Maybe they'll end up in jail or a hospital. We will give you a week or so with the location being unknown. We may be able to keep it open for a little bit, but if the location remains unknown, we're eventually going to say, I'm sorry, we need to close this out until you know where the person is. And like I said, you can let us know about secondhand information, but we're wanting you to provide the other witnesses' info and contact information so that we can get in touch with them directly. Another important thing to note is that patients that are in a hospital can only be referred by hospital staff. So we will sometimes get a call from a case manager or a family member saying, my loved one is in the emergency room and I would like you to go evaluate them. The hospital staff have to be the ones to decide whether or not someone meets the criteria to be held there for that 6 to 12-hour period waiting for the DCRs to come. So as a case manager or a family member, you can call us and give us a heads up that this person has been sent to the hospital and is there and that you're hoping that we'll be able to evaluate. And we can then call the hospital and say, hey, this is what's going on, and we're hoping you'll let us come see them there. But ultimately, the hospital has to say, yes, we would like you to come see the person. It's up to them. And that is the entire presentation.